So, hi everyone, and welcome to today's Journal Club. I'd like to thank IGCS and ESGO for their support in our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. Participants with cameras turned on may appear in the video recording. We ask that everyone please keep your microphones muted so everyone can hear the presentations. If you're having any difficulties or questions, please send a message in chat and our technical support will assist. We'll have time for Q&A and encourage you to submit questions via the chat function throughout today's session. And with that, I'm happy to hand it over to Dr. Reni Pareja, who will host today's meeting.
Hi everyone, this is Rene Pareja, Associate Editor of International Journal of Gynecological Cancer. Welcome to this monthly article Journal Club. The title is Prognostic Factors in Patients with Endometrial Cancer with Isolated Lymphatic Recurrence by Ilaria Capasso and Andrea Mariani. I am pleased to welcome them to join us. Ilaria, Andrea, thank you for being with us today and sharing a deeper insight into this great article. I'm going to hand it over to you for a summation of the article. Let's proceed.
Thank you so much for the introduction and for having us today. We can start with the presentation. Our study is prognostic factors in patients with endometrial cancer with isolated lymphatic recurrences. And just to have a little background, we know that recurrence in endometrial cancer has already been studied extensively in the literature, with evidence suggesting that both the number and location of recurrences may be associated with specific prognostic outcomes. And we know that around 10 to 20% of patients with early stage endometrial cancer disease will experience a recurrence. And with a lymphatic component, which is present in approximately 4 to 20% of early stage endometrial cancer and up to 50% of advanced stage endometrial cancers in the absence of previous adjuvant radiotherapy. And isolated lymphatic recurrence, which is the topic we're focusing today, is a rare finding in endometrial cancer. And we have to recall what ESGO Consensus 2021 says about oligometastatic recurrent endometrial cancer, which is defined as a state of limited metastatic tumor, so meaning 1 to 5 locations that may benefit from additional treatments such as surgery or stereotactic radiotherapy. However, there's a little gap in this knowledge because we know that there's very limited evidence regarding nodal recurrence in general, and particularly on isolated lymphatic recurrence. And therefore, both European and American guidelines cannot really define a specific management for this specific kind of endometrial cancer recurrence. The aim of our study was to analyze the clinical pathological features and oncologic outcomes in a patient with endometrial cancer who develop isolated lymphatic recurrence, stratified by recurrence sites and treatment approaches of the recurrence. These are our methods. So ours is a retrospective single-center study performed at Mayo Clinic, Rochester, Minnesota, between 1984 to 2017, and we included all figure stages endometrial cancers undergone complete primary surgical staging and all epithelial histology, and of course patients who gave consent to research participation. We excluded patients undergone neoadjuvant treatment and patients who had synchronous cancers. Importantly, we defined isolated lymphatic recurrence as the first and unique evidence of recurrence in lymph node-bearing areas after primary surgery, without any concomitant vaginal, hematogenous, or peritoneal recurrence. And isolated lymphatic recurrence sites were defined and distinct in pelvic isolated lymphatic recurrence, para-aortic, distant meaning any other lymph node bearing area, such as the groins or the axillary areas, and multiple site, which is the combination of more than one lymph node bearing area. And the diagnosis of isolated lymphatic recurrence was in all cases by imaging, so CT scan or MRI, and biopsy for histologic confirmation was performed whenever appropriate and at clinician discretion. These are our results. So first of all, we observe among more than 4,200 patients with surgically staged endometrial cancer, we observe 66 patients with that develop isolated lymphatic recurrences. So it's 1.6%, which we can agree it's a pretty low percentage, so it's a pretty rare phenomena. And overall, cause-specific survival for patients with isolated lymphatic recurrence was 24 months. And survival was similar between the 4 isolated lymphatic recurrent sites. So this means that pelvic, paraortic, multiple sites, and distant recurrences had a similar survival. But importantly, however, we observe almost half of our patients with isolated lymphatic recurrences in the paraortic area that were long-term survivals. So this means that they survived 5 years or more after the recurrence. And at multiple variate Cox regression, the absence of lymphovascular space invasion and grade 1 histology in the primary tumor were significantly associated with an improved cause-specific survival. And patients with isolated lymphatic recurrences underwent surgery for recurrence with or without other associated treatments, had an improved survival compared with patients that didn't undergo surgery at all for the recurrence. And this was true also after adjusting for the age of the patients. So concluding, we observe these 2 main findings: lymphovascular space invasion negative, and FIGO grade 1 in the primary tumor positively influence prognosis in patients with isolated lymphatic recurrence. And importantly, in carefully selected patients with isolated lymphatic recurrence, surgical management with or without other associated treatments could increase survival. Thank you so much for your attention, and this is our visual abstract.
Thank you, Hilaria, for this wonderful summary. We will now spend the remaining time on answering questions and group discussions. Attendees, we encourage you to submit questions via the chat function, and we will do our best to address as many as possible. We're going to start out with some questions by our fellows. I think the first one is Jorge. Let's proceed.
Yeah, thank you so much. Hello, how are you? Well, thank you so much, Dr. Agapazo and Dr. Mariani, for this amazing presentation. So the first question is, the introduction of minimally invasive surgery in the USA took place around the 2000s, and your court includes surgery performed between 1984 and 2017. It will be interesting to assess whether the change in surgical approach may have affected the type and timing of this recurrence. Did you make any analysis on this?
So I will answer this question, and thank you for this. At the Mayo Clinic, we have started to perform minimally invasive surgery for endometrial cancer systematically in 2005, 2007. But in this analysis, we didn't specifically look at that characteristic. However, there is reasonably good evidence in the literature that open and minimal invasive surgery, they have a similar overall outcome. We have the LAP2 study. We did a study also with Mayo Clinic and MD Anderson. We did a meta-analysis. And so it's unlikely that we will have big differences due to the open versus minimal invasive. However, if we look at instead the patients who had the sentinel nodes versus a full lymphadenectomy, we did a study with Memorial Sloan Kettering, and what we observe is that patients who had sentinel nodes, they were more likely to have para-aortic recurrence. And so it is possible that with the sentinel node, we may observe more para-aortic recurrences. However, this is overall retrospective data, and certainly it needs to be confirmed by more data. But thank you for this question.
Thank you, Dr. Mariani. I see a question from the chat box. Someone asked that why PET-CT is not considered in recurrence setting. And Dr. Capasso or Dr. Mariani, what's your thoughts on this for this question?
No, frankly, we had the PET-CT. It was just part of the imaging. Perhaps it was not just reported, but certainly the recurrence was reported by imaging. It's true that this was a very large study, so probably patients in which the PET-CT was used were minimal, but overall it was either imaging or biopsy. So yes, PET-CT was part of the diagnosis. Thank you.
And I think Guido has a question.
Yes. Hello, everybody. Thank you very much, Dr. Capasso and Dr. Mariani, for this great manuscript, and also for answering some of my questions during the podcast. I have one more question, which is more technical about statistics, and it is, why was the univariate analysis specifically adjusted for age at primary surgery?
Okay, I can answer this question. Thank you so much for your question. As this is a retrospective studies, patients with isolated lymphatic recurrence were not randomized beforehand into treatment arms. So they were therefore selected beforehand for surgery or other treatments based on their level of fitness for surgery, which mainly includes the age, the BMI, and comorbidities of patients. Indeed, this potentially represents a bias of our study, and it's therefore listed among the study limitations. In the attempt to reduce this bias as much as possible, we adjust our statistical analysis for the age. And even with this adjustment, surgery with or without other treatments was still significantly related to improved cause-specific survival, even at multivariate analysis. However, age is not the only factor in the equation when we need to determine if a patient could be a surgical candidate. As I mentioned before, also BMI, comorbidities, and surgical feasibility and resectability are indeed factors that generally are considered. And we did not adjust for all of these factors in our study due to the small number of our population and also the retrospective nature of our study.
Thank you.
You're welcome.
So I think Giuseppe Caruso has a next question.
Yeah, good morning, everyone. First of all, congratulations, Ilaria and Dr. Mariani, for this great article. My question is regards a specific finding that it was not statistically significant, but I think it was quite interesting. And it's about those nearly half of patients with para-aortic isolated lymphatic recurrence that were defined long-term survivors. It was not statistically significant, but this statement, I think it's very interesting. And I just wanted to ask if you have thought about possible explanations for this, if it is possible that maybe, I don't know, since most of the patients underwent para-aortic surgical staging, maybe the extended field radiotherapy was not routinely performed, and so para-aortic areas were not irradiated, and so maybe surgery was more feasible. I don't know if this is a possible explanation, or if you thought about other potential explanations for this. Thank you.
No, thank you for this question. And frankly, the reason of this may be a combination of these. As you see, the para-aortic area generally received less likely to receive radiotherapy than the pelvis. And I agree also that anatomical areas that are not irradiated are more easy to be treated surgically. And so the irradiated field is not always a very good field to be treated surgically. So, and it is also true that that recurrences that occur in irradiated areas like the pelvis are probably more aggressive because it's a disease that is like resistant to radiation therapy. So all of the things that you are saying are certainly true. But I would add also another thing that in our Mayo experience, the majority of para-aortic recurrences are associated with distant disease, with peritoneal or hematogenous disease. And therefore, if you think about that, it is possible that patients who have an isolated para-aortic recurrence, perhaps they have a biologically less aggressive disease. And so that may be also another reason for which when we see an isolated para-aortic, it's a patient with less aggressive disease. But thank you for this question.
Thank you very much, Dr. Mariani.
So, Dr. Capasso, Dr. Mariani, I see some questions from the chat box, and they are asking if there was any subgroup analysis with respect to the molecular subtype versus recurrence.
I can try to answer this. Unfortunately, we don't have this information on molecular analysis in our retrospective study, but we saw this question could come up due to the fact that molecular analysis is now the hot topic in endometrial cancer research. So yes, if we do believe that the integration of molecular data could be very informative and provide further relevant information and associations with the specific pattern of recurrence. There are relevant studies that are pretty recent, such as the study from Venice, I think, observing that certain molecular groups are related to certain kind of recurrences and also specific sites of recurrence. For instance, mismatch repair status is associated significantly with the presence of lymphatic metastasis compared to the other molecular subtypes. And also there's another recent study, I believe from Siegenthaler, that show that mismatch repair endometrial cancer are more likely to recur loco-regionally and compared to P53 abnormal and NSMP endometrial cancers. So and maybe this last one, so P53 and NSMP have a trend, high rate of distant metastasis instead. So yes, this area needs to be further investigated in future study. That's true.
Thank you so much, Dr. Capasso. So I think Dr. Matt Wager from Wisconsin has a question.
Yeah, thank you, Dr. Capasso, Dr. Mariani, for coming. This has been really great. You know, in this study, the majority of patients were identified to have advanced stage disease, but only about a third of them received adjuvant chemotherapy, which is becoming more commonly utilized in the adjuvant setting for these patients. How do you interpret your results in a changing patient population that's predominantly receiving chemotherapy as a part of their adjuvant treatment after staging?
Thank you. I can try to answer your question. We can hypothesize that in nowadays populations of endometrial cancers, they are more frequently treated with adjuvant chemotherapy than before. Recurrences may potentially develop a little later in time. but also it may be possible that recurrences may also be more biologically aggressive due to a potential natural selection of a more aggressive tumor cells escaping from the adjuvant chemotherapy. But in this regard, however, it must be stated that in the GOG 258 trial, it was, in their results, it was by adding radiotherapy to chemotherapy that resulted in a lower rate of both pelvic and para-aortic recurrences compared to the chemo-only group. So in this specific setting of nodal recurrences, probably radiotherapy plays a more important role than chemotherapy, I believe.
Thank you so much, Dr. Capasso. So next, I think Dr. Giuseppe Cucinilla has a question.
Yes, hi everyone. First of all, thank you to Maria and Dr. Capasso for being here and congratulations for this paper. My question is about the selection of the patient. So the ESGO guidelines state that the endometrial cancer recurrence should be considered for surgery only if it's anticipated that complete resection of the macroscopic disease can be achieved with a reasonable morbidity profile of the patient. So along with this assumption, what do you think about the findings of your study, and if these factors can be incorporated into a new algorithm that can include also tumor characteristics such figure grade 1 or negative LDSI? So how these findings can be incorporated into a new algorithm? Thank you.
Thank you, Giuseppe, for this question. And certainly this is a retrospective study, and certainly it's biased. And I don't know if with this we can change the guidelines, but it is also true that the data on this topic in the literature are extremely limited, and it is unlikely that we will have prospective randomized trials. So what we can say based on our study is that it's reasonable that if we have a grade 1 primary tumor with no lymphovascular invasion in a patient with isolated para-aortic, it may add the strength to the evidence that we can, it's probably reasonable to treat this recurrence with surgery. In our series, it's usually surgery associated with some other type of treatment. But thank you for your question.
Hi, Andrea, and hi everybody. I'm sorry I arrived a little bit late. It's great to see everyone, and it's great to see Andrea also, who got as dressed up as me for this journal club. Andrea, I wanted to ask you, so following along with that, you mentioned the surgery and then followed by radiation. What are the type of patients where you have an isolated recurrence in the lymph nodes? And you might have already addressed this, and I apologize if it's already been addressed, but where you basically say, let's just go straight to radiation therapy, where there's, the added risk of surgery, the potential complications, the potential delay in starting treatment. Why not just go straight to radiation? What is that patient population?
And and thank you for your question. And certainly is the patient selection for surgery. So certainly we select patient based on age, based on performance status. So certainly, and this is a retrospective study, so there is this bias inside of this. But certainly if the patient is not a candidate, especially for a big surgery, many times this patient may undergo a big surgery. Those are certainly the patient in which we are more likely to go straight to radiation. And but it's also part of a discussion at tumor board, also with our radiation oncologists as well.
Yeah, and then as a follow-up to that, is there any one, when you're looking at that imaging, provided that the patient is perfectly healthy to go to surgery, and fit to go to surgery, when you're looking at that imaging, is there any one particular area in the periodic area where you say, I'm going to offer radiation rather than go to surgery? In other words, lymph nodes above the inferior mesenteric or lymph nodes behind the aorta or in between the aorta and the vena cava or by the renal vessels, where you say likelihood of doing damage is much more than the benefit of removing it?
No, certainly that's very reasonable. I wouldn't say that that's an absolute contraindication, because in a patient, in a relatively young patient fit for surgery with a grade 1, and this is the only area of metastasis, we may still decide to approach this surgically, even if it's in a difficult anatomical position. So certainly the anatomical position comes into place when, and we need to take this into account. If it's like around the renal vessels, certainly that's a difficult area. I wouldn't say it's an absolute contraindication, but certainly it's a very important assessment.
Great. And I think Rene Pareja has a question for the authors.
Yes, yes. Thank you, Pedro. Andrea, did you include in patients undergoing just sentinel node detection? And if yes, is there any difference in those patients' pattern of relapse between those undergoing just sentinel versus full pelvic and periaortic lymphadenectomy?
Yeah, so we have just a limited number of patients who had sentinel nodes, because this was a population from 1984 to 2017. We started to do sentinel node in 2013 at Mayo. And so taking into account that this is just 1% of our recurrences, and to have a recurrence, you need time, and so we cannot say that based on our data. However, looking at data of our comparison between Memorial and Mayo, we actually see that in patients with a disease in the lymph nodes, when they have just sentinel nodes, they are more likely to have a paraortic recurrence. So it is possible that we may see more paraortic recurrences as we go ahead and we continue to treat patients in this way. At the same time, as we were saying before, the paraortic recurrence, many times, if it's in a patient with aggressive disease, it is associated also with distant recurrence. And so most of the time, it's probably not the paraortic lymphadenectomy that is going to save a serous endometrial cancer patient who is recurrence. While patients with grade 1 and isolated paraortic recurrences, those seems to be the right patients that may benefit for an aggressive approach. But thank you for this question.
Thank you, Andrea.
And Andrea, just Ilaria, and you might have again addressed this, but is there a particular algorithm that you look at in making the decision based on histology? So if you have like an isolated recurrence of a carcinosarcoma, do you treat that the same as an isolated recurrence in the periodics of endometrioid?
Do you want to go, Ilaria? Or?
Yeah. Well, due to the fact that histology is strongly related with grading, I believe that since our results said that we consider grade 1 as related to better prognosis, carcinosarcoma, or in general non-endometrioid tumors that are likely grade 3 are generally related to worse outcomes, even in our study. Even though we didn't observe any differences in terms of stratification of histology between among our isolated lymphatic recurrence groups. So I think that we should be more careful in this in a patient that is non-endometrioid, or in general it's not grade 1, to treat her with surgery, I think. I don't know if Dr. Mariani is agree.
I agree with Ilaria, and certainly that's a very important point. We take into account that 2/3 of patients with serous endometrial cancer, they recur either hematogenous or peritoneal. So it's always something that we need to take into account, the histology. And so to do a big surgery on a patient with a carcinosarcoma, it's likely that a few months later, this patient will have distant disease, and so they may not be the most appropriate patient. Thank you for this question.
Great. So I think our next question comes from our fellow Luigi De Vitis, and I think it's related to what about no surgery or radiation? Luigi?
Yeah, more or less, I'm following this line. When first of all, I would like to thank Dr. Mariani and Ilaria, and I'm really happy to see you here today. Also, I would like to know how you interpret your results in the context of the new emerging evidence on immune checkpoint inhibitors for patients with recurrent or advanced endometrial cancer. Thank you.
I can try to answer your question. Thank you so much, Luigi. It's very nice to see you again today. So ours is a retrospective study, as we already mentioned. We have included an old population, so patients from 1984 to 2017, and at that time, immune checkpoint inhibitors were not a treatment option at all. So in recent and relevant published studies, immunotherapy has been shown to have a huge potential for significantly improving prognostic outcomes in the setting of both advanced and metastatic endometrial cancer. For example, in the RUBY trial, dostarlimab is just an example. And therefore, we don't know and cannot exclude that target therapies in this specific setting of recurrence may yield even better survival outcomes than surgery with or without other treatments, or maybe even the combination of the two, so of the two approaches, so surgery with or without other treatments and immunotherapy, for example. Maybe this could be an option that it's even better than surgery alone. We don't know. Unfortunately, we don't have evidence in the specific setting of isolated lymphatic recurrence to answer these important questions to date. And based on our retrospective analysis, which is the only data specifically on isolated lymphatic recurrence to date, it looks like surgery with or without other treatments could be the optimal option for very selected patients with isolated lymphatic recurrence. But surely this needs to be addressed in the future.
Thank you.
Yeah. And we do have a question from the chat, but as a follow-up question to Luigi's question, there are times when we look at a patient that has somewhat not the best medical condition to go to surgery, or perhaps the recurrence is in a site where there's a high risk of injury if you went to surgery, and the radiation oncologist says, based on the size of that recurrence, that's too big for us to control with radiation. Is there any point, or what are your approaches in terms of saying, well, we'll start with systemic therapy, be it immune checkpoint inhibitors, chemotherapy, sort of like as a neoadjuvant approach? And you often hear this in tumor board where you say, start treatment and see how she responds. And if she responds well, then we'll go after surgery or radiation. But if she doesn't, then we already knew that she wasn't going to benefit from treatment. Just wondering your thoughts on that.
Yes, I agree with that, certainly, and we do that approach as well. And that approach also allows us to see again that the tumor is responding to the treatment, and that the patient doesn't develop a distant disease in the meantime. So that's certainly a very good approach. Thank you, Pedro.
All right, and then we'll go to Seda in Turkey.
Hi, everyone. Thank you, Dr. Capasso and Mariani, for this great presentation. Firstly, as you know, at ESGO 2023 Congress, ENIGO will organize a boat tour at 28 September. So don't miss this opportunity and take your ticket from Congress website. And I'm sure that you won't forget the beauty of the Bosphorus. And question is, wouldn't it...
Oh, there was a question. No, I thought it was just the announcement.
Bosphorus PR. And now my question, wouldn't it be an additional contribution to this study to look at the molecular profile in isolated lymphatic recurrence cases? I know Dr. Capasso mentioned a little, but want to hear again.
Yeah, sure. Thank you so much for your question and for the invitation in ESGO 2023. And yeah, it's definitely, it's a yes. And as I mentioned before, fortunately, we don't have this information on molecular analysis in our population, but we believe that it could be a great integration, the molecular analysis that could be really informative and provide associations, significant association with this specific pattern of recurrence based on the two studies that I mentioned before. So the needs that said that mismatch repair deficient status was significantly related to the presence of lymphatic metastasis when compared with the other molecular groups. And also in terms of sites of recurrence, and according to other recently published studies, mismatch repair deficient endometrial cancer are more likely to recur locally compared to P53 abnormal and NSMP endometrial cancers that have a higher rate of distant metastasis. And also it has been observed a trend towards a higher rate of abdominal metastasis for P53 abnormal group compared to the other molecular groups. So yes, it needs to be further investigated, especially in the light of the new FIGO staging system that gives much more importance of molecular analysis than ever before. So yes.
Excellent. I think that there's an additional question from the chat, and we're coming towards the end of the journal club. We have about five minutes or so, and I'd love to hear the response from both of you. And Ilaria, I'll start with you. But basically, the question is centered on the fact that if you get a phone call from a colleague in Palermo who says, all right, I read your article, I saw the journal club, how do I apply this to my patients? And what do I tell them? And how will this data help me manage my patient next Monday?
So I think that our results should be taken like a general indication, cannot be applied to every case. I believe that every case should be managed by a multidisciplinary team to tailor treatment of the recurrence for each patient. So it's something that cannot be generally applied to patients as it is, because it's just the first evidence on the specific sites of kind of recurrence. So I think that the first thing that we need to apply is the standard that we have done so far. So considering the fitness for surgery, age, comorbidities, and performance status. And then when we have DUBs, we can apply what we found with our results. So maybe a para-aortic metastasis in a patient that had a grade 1 lymphovascular space invasion negative in primary tumor. Maybe we are more likely to send her to surgery than other kind of patients.
Okay, excellent. Andrea.
I agree with Ilaria overall. So again, these are general recommendations that we can give. We can add that the grade is important. And also I wanna, because in that question, they mention also about the fact that can we give surgery without anything else? Just in this paper, the vast majority of patients who had surgery, apart from one patient, they all had something else after surgery. So in general, it's an approach that is a multidisciplinary approach, but thank you.
Excellent. Well, thank you both so much. I want to obviously thank you for sending your manuscript to our journal. Thank you for your time and answering everyone's questions. We're all really very Seda, thank you for the invitation to Istanbul. We're all incredibly excited to be there, and we look forward seeing everyone there. I know that Nico is also on the call. If there's any specific additional information you want to give about this boat tour, I think this is the time to share it, and please highlight if there's going to be an alcoholic tour or non-alcoholic tour.
Thank you, Pedro, and thanks, Seda, for this great invitation. We look forward to seeing you there. It will be absolutely an alcoholic tour, so don't worry about that.
Okay, Renee, you can come.
It will be on Thursday night. We start after the welcome ceremony. Just right after, we go straight with the bus to the port, and from there, a couple of hours tour where we stay all together, we drink, we have something to eat, and we will just make network. So I think it's a great opportunity to stay together and to share our experiences.
And tickets must be bought ahead of time, or you can buy them on site at registration?
So I would advise you to buy the tickets beforehand. You can find them on the registration website, on the Congress website, because I'm afraid there could be some issues there. So there are plenty of tickets, but please, I would advise you to buy in advance. If you have any trouble, please send me an email or a text. I'm always available to help. Thank you.
And as a courtesy to Ilaria and to Andrea, I think your entries to the boat tour are free for doing this journal club.
Yes, and also to all moderators.
Exactly. Well, thanks everybody, and we'll see you next time for the September. Actually, let me just reiterate, for the September journal club, we're going to have the topic of low-grade serous ovarian cancer, an expert consensus report on the state of the science. So how do we treat low-grade ovarian cancer today? So look forward to having you all there. Take care.
Thank you.
Bye. Thank you.
Bye.